Welcome to AETCM, the emergency medicine channel. In this part 2 of cardiovascular emergency, we are going to discuss regarding the acute coronary syndrome. So before starting in this chapter, I skipped some of the section like ECG and then ACLS, BLS, tachycardia, bradycardia. Already those are the things, recorded videos we have in our AETCM channel itself. So you can go through, those are the videos. So coming into this presentation, so ACS, acute coronary syndrome, that is characterized by the diminished blood flow through the coronary arteries. So coronary arteries supplying the muscle part of the our heart, so myocardium. So that is the thing, coronary artery diminished blood flow through the coronary arteries. So the reason is either it may be an coronary artery occlusion or coronary artery spasm or reduction of overall blood flow. So to understand this concept, if you remembering the perfusion triad means it will be easy for us. So perfusion triad we know, so you should if you want a effective perfusion means you should have a adequate pumping action, pumping function, that is the cardiac function, and then second we need a container, intact container. Container means that is the blood vessels, so you should have a intact blood vessel and then you should have a blood, otherwise content. Okay, so per pump we should have a pump and then we should have a container function and then we should have a content function. So if anything, if any problem happen in one system also, that will affect the perfusion if anything. So here we told coronary artery occlusion and then coronary artery spasm. So that means the problem in the container. Again shock or dysrhythmia means problem in the pump. So that is why, so if any problem in the three system means that will affect the perfusion. So here acute coronary syndrome, that includes the myocardial ischemia, infarction and then unstable angina. So this is about the normal anatomy of the coronary vasculature. So first we have a two major branches, right and left coronary arteries. So both thing originate from the root of the aorta. So right coronary artery have a two major branches, that is posterior descending artery. This is the posterior descending artery. This is the right side marginal artery. So by seeing this picture we can understand wherever it's supplying. So posterior descending means it is going inferior and then posterior part of the, majorly posterior part of the right ventricle it is supplying. Then other branch, the posterior descending also, it is the branch extending till the septal region also, till the interventricular septum. So the other branch like a right side marginal artery, it's supplying the anterior part of the right ventricle. In other hand, if you go in the left side coronary artery, that have a two branches, like first one is a left side circumflex artery. So circumflex artery that continues as the left side marginal artery. So here you can see the anterior part and then it is going the lateral wall also. So lateral and then posterior wall, it extending till the septal region. So again left anterior descending artery that continues as the diagonal artery that majorly covering the left ventricle anterior part. So this is the anatomy of the coronary vasculature. And then what are the risk factors for the ACS? So here we are classifying into modifiable and non-modifiable. Modifiable means diabetics, like excessive alcohol use, high cholesterol, high lipidemia, and then high blood pressure, hypertension, obesity, physical inactivity, smoking, stress, unhealthy diet. So modifiable means if you are taking diabetes, if the person is diabetic means we can give some treatment and then we can reduce the risk factor. That is the modifiable. Non-modifiable means age, family history of coronary artery disease, sex and then rate ethnicity. Then what is the pathophysiology behind the acute coronary syndrome? So ischemia happening because of the imbalance between the oxygen demand and the oxygen supply. For example, if your cell want the 100 molecules of oxygen means that is the demand. Okay, so but your blood, otherwise your body is supplying only 40 molecules of oxygen means that is the supply. So here demand is increased but supply is reduced. So that is the imbalance between the demand and then supply that causing the ischemia. And then second concept, If you want a oxygen supply, proper oxygen supply means that needed two major things. First one, oxygen carrying capacity of the blood. Second one is coronary artery blood flow. So you can remember some online delivery. So if you want to deliver something to some other area means, so you should need you need a proper vehicle, and then you proper vehicle alone, not alone the proper vehicle, you need a proper pathway. So here vehicle is an oxygen carried by the hemoglobin. So vehicle should be there, mean the same time you should have a proper pathway. So that is the coronary artery blood flow. The blood flow is determined by the duration of diastolic relaxation and the peripheral vascular resistance. Here there is a coronary vascular resistance. So usually acute coronary syndrome happens because of the ruptured atherosclerotic plaque. So atherosclerotic plaque means what? Atherosclerosis means it is a condition in which thickening and stiffening of the arterial wall. So that will reduce the elasticity of the artery. So we'll see this concept here. So how the arteries, how the coronary arteries getting thickening and stiffening means, so first we'll see one by one. So first pathology is so this is your coronary artery, right? So here you have a from, if any injury happen in the coronary artery means the first response from your body is first it will settled by your fat. So some fat material that will deposit gradually over the plaque area. So sorry, gradually deposit over the injured area. So but here they are mentioning atherosclerotic process probably begins in from the childhood itself. Gradually the deposition will happen in the intimal layer of your coronary arteries. Intimal means innermost layer. Okay, so the day goes, so gradual deposition that will develops like a mass, fat mass, that will develop like a fat mass. So day by day it will develop, it will fast, and then it will goes like a fat mass. So once after, and sometimes what will happen means, so here in this side, so it is a blood circulation. So in our blood circulation usually we'll have a calcium, and then we have a electrolyte sodium, potassium, calcium. So the calcium will adhere these sides. So like this, the calcium also adhering in this area. So calcium what will cause means, so it will cause the stiffening, so it will cause the thickening of the layer. Usually our coronary artery, otherwise our artery will fluctuate based on the systolic and then diastolic of the heart response. But because of the because of the fat deposition, and then because of the calcium, the artery gets stiffening. So before that the vessel is this much of dimension. Now because of the deposition, that vessel dimension get reduced. Mean the same times that will cause, so that narrowed lumen will cause the turbulent blood flow. Turbulent in the sense, so we have a two types of blood flows, like laminar. Laminar means that will go straight for steady blood flow. Turbulent means wherever you are getting the narrow lumen, that will give some forces. So that is the turbulent blood flow. Second thing, it will cause the, that narrow lumen cause the reduced blood flow to the area. That is the second pathophysiology. Third pathology, what will happen means, in this area there is a potential risk for the thrombus formation. In this area there is a potential risk for the thrombus formation. So again, so already you have a fat deposition, over there you have a calcium deposition, over there if it is thrombus also formation means complete obstruction of the coronary artery will happen. Mean the same time, if sometimes if the atherosclerotic plaque, the same thing. So whatever things, fat deposition, calcium, and then thrombus, it get dislodged, and then it can travel along the way wherever in the circulation, and then some area it will dislodge it, and then it will cause the problem. So this is the three major things. So it will obstruct the inner lumen. Mean the same times it will create the turbulent blood flow. Third thing, it is the major risk factor for the thrombus formation. So that is the pathophysiology. At final, we can understand atherosclerosis in a condition which thickening and then stiffening of the arterial wall that greatly reduce the elasticity of the arteries. So clinical features wise, mainly the person will complain the angina pectoris, means that is a chest discomfort. So angina pectoris we are classifying into three categories: stable angina, unstable angina, and then princemetal angina. Stable in the sense, so if you are doing any physical activity, the person is doing in assessment part we told if the person climb 10 or 12 steps means they will get a chest pain. That is because of the some exertion person is getting chest pain means that is the stable angina. Unstable angina means even with the rest also the person will get the chest pain. That is the unstable angina. Princemetal in the sense that is the vasospasm, because of the coronary vasospasm that will occur. So here we given the some differences. So in stable angina characteristics wise, that is the predictable location, intensity and duration. But unstable angina that will change. It won't show the predictable location. The person will complain first time in some other areas or second time in some other area. Third thing is a princemetal angina. So that usually occurs in a rest position, like that also cause the because of the emotional stress and then hyperventilation and then cold weather exercise also, that will aggravating factors. So predictability wise, stable angina is predictable. So as like we told, climbing as 10 steps, otherwise climbing the slope will produce the angina. So that is the predictable. Unstable angina is unpredictable. And then palliative factor wise, stable angina that will relieved by rest and then medication, unstable angina that may or may not relieved, and then vasospastic also like stable angina it will relieve by the rest or medication. So ECG changes wise, so wherever you are happening the ischemia means that will cause the depression of, otherwise depression of ST segment and then inverted T waves. So if it is a infarction means that will cause the elevation, ST elevation will happen. So here because of the ischemia, ST segment depression, otherwise or inverted T waves will be there, but in the vasospastic angina that will cause the ST segment elevation. So risk wise, unstable angina impending myocardial infarction, princemetal angina that will cause the dysrhythmias or arrhythmias, acute myocardial infarction, syncope and then sudden death. So differential diagnosis. So some of the clinical features will mimic like these conditions. So like pulmonary embolism, spontaneous pneumothorax belongs to the pulmonary system. So otherwise respiratory system, aortic dissection and then acute pericarditis, that is also from the cardiovascular system. So musculoskeletal causes like costochondritis, kyphodynia and then pericardial cat syndrome, intercostal strain because of the cuffing. So and then GI causes gastrointestinal like GERD, gastroesophageal reflux disease, peptic ulcer disease and then esophageal rupture also some of the differential diagnosis. So how we can diagnose, otherwise how we can assess this patient. So first step is so here we told major clinical feature is an acute angina pectoris. So angina pectoris in our assessment part itself we told, so apply the OPQRST mnemonic, onset and origin of pain, P in the sense provocation and palliative factor, Q in the sense quality of pain, R in the sense radiation and then region, S in the sense severity, T in the sense time. So here, so the same thing we are applying, that here time is most important. So in acute coronary syndrome they will tell us that time is a muscle. So if you given if you wasted some time means you are losing the muscle. So that is the time is muscle. So here you have to note the time of symptom of onset, time of first medical contact. So otherwise arrival on scene, time of acquisition of 12 lead ECG, time of identification of STEMI, time which aspirin was administered. If not means why you didn't administer. That is the reason we have to mention. Why this time is most important means for the definitive therapy management. So for definitive therapy management, what is mean that we'll discuss. So first is an definitive therapy means will definitive therapy have a two approaches. So we'll do the percutaneous coronary intervention. So we'll insert some stent and then we'll insert a balloon. Those are the some steps are there. One procedure that is called percutaneous coronary intervention. Then second step approach is an fibrinolytic therapy. Fibrinolytic therapy, streptokinase, urokinase, those are the some pharmacological agent that will introduce and then that will we will break the clot. That is the two approach we have. So first these are the some time interval we have to keep in mind. So first is a EMS to balloon time. So this time means that is the duration between the first medical contact to the percutaneous coronary intervention, the duration. Second thing, this is the most common, it's the uncommon one. Here it is the most common, door to balloon time. So this is the duration between the person arrives the hospital between the and then percutaneous coronary intervention. So here we should done within 90 minutes. So once the person arrives in the hospital, within 90 minutes you have to take the person into the percutaneous coronary intervention procedure. So that is time interval is most important, within 90 minutes. Door to needle time means, needle means there is the thrombolytic therapy. Okay, so within a 30 minutes you have to perform the fibrinolytic or thrombolytic therapy. So that is called the door to needle time. So the time duration between the arrival of hospital, the person arrival of hospital to the fibrinolytic therapy. And then next is a diagnosis. Second part, that is a history and physical examination. Ultimately ECG is one of the tool we are using in the cardiac system. So as soon as possible we have to do the ECG. Otherwise within ED means, in ED means within 10 minutes you have to do the ECG. So interpretation wise, new ST segment elevation, it is more than or equal to 1 millimeter in two contagious leads. So more than 1 millimeter means normal criteria. What about the normal criteria in ST segment? So it should not elevate or depress more than 0.5 millimeter. So that is the normal criteria. If it is elevated more than or equal to 1 millimeter in two contagious lead means that indicating the myocardial infarction. Two contagious means, so like if inferior wall MI means you can see the changes in the lead 3 AVR, lead 3 and then AVL and then AVF. So that is the contagious leads. So if it is a changes in means, then you can remember that is the myocardial infarction. So the person need indicate the reperfusion therapy. So and then second condition is a new ST segment elevation, otherwise any deep Q wave. Here you can see the deep Q wave. Okay, deep Q wave, otherwise any left bundle branch block, a new onset of left bundle branch block. So the criteria for the left bundle branch block, here you can see the in lead 1 there will be a white QRS, V6 also white QRS, M like a pattern in V6, and then you can see the inverted T wave in the V6. That is the criteria for the left bundle branch block. And then T wave insertion and normalization in symptomatic person, they are suggestive of the ischemia. So further investigation should be taken. So the two major things, first thing, any elevation of ST segment more than or equal to 1 millimeter, that is indicating the myocardial infarction. Straight away we have to think about the reperfusion therapy, definitive care. Second thing, new onset of ST elevation, deep Q wave, left bundle branch block, T wave inversion, those are the some other categories, they are indicating ischemia. So these are the contagious leads. So inferior wall MI means 2, 3 AVF, lateral wall MI means lead 1 and then AVL and then V5 to V6. Septal wall MI means V1 to V3, anterior means V1 to V4 and then loss of Q wave in the V by V6. Right ventricle means V1, there will be a changes in V1, right sided V4, posterior wall MI means V7 to V9, atrial related means V1 to V6 changes will be there. So management wise, same management. So we have to start with a scene size up, scene safety, everything. So here, as like we told, reperfusion therapy, there is a two approach, percutaneous coronary intervention and then fibrinolytic therapy. So before that, in pre-hospital and in-hospital, we can do some symptomatic management, that is called MONA. There we have one mnemonic that is called MONA. M in the sense morphine, O in the sense oxygen, N in the sense sublingual nitroglycerin, A in the sense aspirin. So this is order for the mnemonic, but we have to follow this order. First you have to administer the supplemental oxygen. Second you have to administer the antiplatelet, that is the aspirin. Third you have to administer the nitroglycerin, sublingual nitroglycerin. Fourth, if so morphine is mainly we are using for the analgesic purpose. So morphine, the role of the morphine here is an analgesic. So most probably with the sublingual nitroglycerin, the person will get better because the pain happening here because of the coronary artery spasm. So if you are giving nitroglycerin, that is the vasodilator. Most of the time it will the person get relief once after a nitroglycerin. If not, means we can go with a morphine. Okay. So nitroglycerin wise, so sublingual 0.4 mg tablet per oral, under the tongue, sublingual you can give, and then meter dose inhaler spray also we can go for every 3 to 5 minutes. So contraindication, if the person have a systolic blood pressure less than 90 mmHg, right ventricular infarction, phosphodiesterase inhibitor, means you should not go with a sublingual nitroglycerin. Then second thing, for aspirin, here we have to administer the non-entry coated aspirin. That is the thing we have available here is a Disprin. So the dose range is 160 to 325 mg we can go for. So as like we told, if the person doesn't get a pain relief from the nitroglycerin, then you can go with a morphine sulfate. Pre-hospital fibrinolytic checklist. So this purpose of this checklist, before transporting the person to the definitive care itself, you have to make a decision whether the person fit for fibrinolysis or not. So here we told two approaches only. Only either the person go with an fibrinolysis, otherwise percutaneous coronary interventions. So before transporting itself, you have to make a decision. For that purpose only they were given this checklist. First, you have to step one, you have to identify whether the person have a chest discomfort greater than 15 minutes, less than 12 hours. Second, if yes means in ECG you are finding STEMI. If again yes or no, yes means then you have to notify any contraindication for the fibrinolytic therapy. So like systolic BP more than 180 to 200 mmHg, or diastolic BP more than 100 to 110 mmHg, interarm, that is the right and then left arm systolic BP differences more than 15 mmHg. Likewise, these are the checklist for the contraindication for the fibrinolytic therapy that you have to check. If yes means straight away you have to transfer the person to the where percutaneous coronary intervention available. That facility you have to give the first priority. Second thing, this is the contraindication. This is the second thing is if the person is high risk for the procedure or not. High risk in the sense heart rate is more than or equal to 100 beats per minute, and then BP is less than 100 mmHg, systolic BP, and then pulmonary edema, signs of shock, contraindication to pulmonary fibrinolytic therapy, required CPR, cardiac arrest scenario, means then straight away you have to transfer the person into the where percutaneous coronary intervention available. And then this is the thing what we are following in inside the hospital. The same thing, first thing, symptom suggestive ischemia infarction. Second thing, this is the thing what we are doing in pre-hospital. So monitoring we have to do, and then we'll do the MONA, and then we'll do the 12 lead ECG, and then we'll manage the symptomatical. No, that is the thing coming under this. In ED, within 10 minutes, they have to do the vital signs, and then they have to repeat the ECG, and then they have to establish the IV access, and then they have to get a brief history. So in light of fibrinolytic therapy, they have to collect the all previous history and then past history, and then they have to go within 30 minutes, they have to perform the portable chest x-ray, and then cardiac markers, electrolyte coagulation study, that laboratory investigation within 10 minutes you have to do. And then in management wise, same MONA management, morphine, nitroglycerin, aspirin, and then oxygen saturation. And then based on the ECG interpretation, we are categorizing into three categories. First one is a ST elevated myocardial infarction. So if you are suspecting ST elevated, means straight away we are going with an reperfusion therapy. So there, before that we have to identify whether the symptom onset is less than 12 hours or not, and that is most important. If it is less than 12 hours, means either you can go with an fibrinolytic therapy, otherwise percutaneous coronary intervention. And then second step is an non-ST elevated MI, otherwise unstable angina. In this case, what we are doing means, so here we won't see any ST elevation. That is the non-ST elevation. But if you go through the troponin level, cardiac enzyme markers, means that will be in a elevated stage. For that cases, we are doing the nitroglycerin and then heparin management, and then we are giving beta blockers, clopidogrel, and then glycoprotein 2A, 2B, and then 3A inhibitors. So this is the step of management for the non-ST elevated MA or unstable angina. Third category is a low intermediate risk for the acute coronary syndrome. Here we have to do the serial cardiac markers like 062. That is it. So first you have to do, and then after 6 hours you have to take, and then after 12 hours you have to take the sample for the cardiac enzyme. The same time we have to do the serial ECG monitoring also. So based on that, if any changes is there means, then we'll shift the treatment based on the changes. So these are the some ED treatments, fibrinolytic, glycoprotein 2B3, 3A, and then other anti-ischemic therapies. So just go through, mainly these are the things will comes in the ER management, ED inside the hospital management. So mainly for pre-hospital management, remember the MONA, first administer, we have to supplemental oxygen, then we have to administer sublingual nitroglycerin, then we have to go for the your MON aspirin, and then we have to go for the, if the pain is not subside means you can go for the morphine sulfate. So these are the whole things regarding the acute coronary syndrome. Do your best. Shalom.